This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today with Jaewon Ryu, the CEO of Risant Health, the fascinating and I think important nonprofit organization formed by Kaiser Permanente in 2024. Risant represents a major new strategy for Kaiser Permanente, and I have had a front row seat in its development when I was serving on the board of Geisinger Health System. Risant isn't a staff model HMO in which patients with insurance through KP keep their care within KP provider circles. Risant includes nonprofit mixed model payer providers like Geisinger. Geisinger's health plan covers many members who don't go to Geisinger providers for their care, and Geisinger's providers take care of many patients who don't have Geisinger insurance. The same is true for Cone Health, the other major system to join Risant so far. It's an important development to see if Kaiser Permanente's expertise and investments in high-value care can be amplified through other types of delivery systems. My take is that it is an idealistic and forward-looking body of work, and even if you are competing with Risant members at some point, we all have to be rooting for success in their efforts to improve the value of care. Jaewon and some of his colleagues recently published an article in NEJM Catalyst on the value-based platform that Risant has introduced, which incorporates knowledge and tools from across KP as well as Geisinger and Cone. Knowing how hard it is to actually change anything in healthcare, I asked Jaewon to spend some time with us today, giving us an even more up-to-date progress report and flesh out how this work is going. So, Jaewon, let me start the way I always start conversations when we get together. How's it going?
Well, it's great to be here, Tom. Thanks again for having me. It's always good to chat and catch up. I think the short answer to your question, things are going great. We made quite a bit of progress over the 2+ years that we've now been in existence. As you referenced, Geisinger being the inaugural system to come into the Risant model, and Cone Health about a year later, actually a little less than. So we've had a pretty good runway of a start with both organizations, and I think we're happy to say that there's been great progress on the value-based platform, and a big part of that, and I'm sure we'll dive into it, is just helping systems to do more value-based care and to do it better and to accelerate their journey on that. And it's focused and targeted to organizations that want to manage populations and communities in that kind of outcome-driven way, sort of shifting the center of gravity to be further upstream and focused, bringing care and services into places that are not the downstream of hospitals and ERs, but instead focusing on prevention, sort of reliably and consistently delivering evidence-based best practices, and doing so in environments that drive greater affordability and better outcomes. So we've been hard at that. And then, of course, at the same time, continue to have pretty robust discussions on work in the pipeline of other like-minded systems that we think would be a good fit for our model.
Now, I'm not going to ask you to tell me who the potential new members of Risant are. I've already tried to get hints from you in private conversations with zero success to my chagrin. But tell us more about the value-based platform. Your article was terrific, but I still can't picture what it would mean if I was a primary care physician at Geisinger or Cone instead of being at the Brigham. What would I be receiving? I mean, I'm imagining emails that, in all honesty, I might be deleting without really reading. What's actually happening there?
Yeah, I think the detail is really important. And I think the big difference between, delivering value-based care in these pluralistic environments, i.e. multi-payer, multi-provider, and bringing these best practices and systems, processes, and technologies to bear, it really is about making the right thing to do, the easy thing to do. It's trying to get patients more advanced and accelerated in their care plan in an easier way, whether it's sort of one-stop shop instead of, having to make a couple different stops. It's limiting the amount of time that they may need to spend in downstream environments like ERs and hospitals. And I think we think of it truly as a platform in that these capabilities all come together or are intended to to create the better care model where people can have the better outcomes and a better experience at the same time. I think the best example is what we call the evidence-based care guides or the value-based care guides. But maybe I'll spend a little bit of time going into that, but it's one of four buckets of solutions within what we call the value-based platform. The first one we call right care, right place. And as the name would suggest, it focuses on the intake and making sure that patients are directed to all the array of options they have to get their care needs met. And to do so as quickly as possible. The second category we call clinician simplicity. And same thing, these names are intended to be somewhat descriptive, but it really tries to remove the administrative burden and friction-laden areas of how a patient flows through the system and how clinicians and care teams experience that. The third bucket is evidence-based care everywhere, and that's the one I do want to dive into because I think it's very illustrative of hopefully the mindset, but also give people a little bit of flavor of what these solutions look like. And then lastly, we call it care across the continuum, and as that name suggests, we do know that despite the best efforts around prevention and moving things further upstream, some people are going to land in those downstream environments like hospitals, ERs, or post-acute sites. And when they do, we want to make sure they're getting well as quickly as possible and plug back into a continuity of care with the receiving end on the outpatient space. So those are the four categories. But if I'm drilling into that third one, the evidence-based care everywhere and the value-based care guides, it really is about getting more timely resolution for patients. You may have a patient go to primary care, and instead of having to then subsequently refer them to specialty care, we're really trying to get as many things addressed in that single site as possible. We've amassed sort of a clinical repository of over 400 conditions, borrowing from the best practices gleaned over many, many decades at Kaiser Permanente, and also incorporating feedback from the Geisinger teams and now the Cone teams, and bringing it into sort of within the workflow, easy and actionable, at the fingertips, if you will, to address the most commonly encountered clinical conditions. When we do that, we've seen some pretty impressive results. Initially we were seeing 4-6% or so relative reduction in specialty referral rates. I think as we get deeper in the queue with users that were already pretty good at adhering to best practice, we're seeing that land sort of in the 4% range. That sounds like a small number, but what that really means is thousands of specialty referrals and care visits that otherwise would have happened, but we've been able to save. And of course, if you think about what's going on throughout the industry with specialty access being so challenging, that means it opens up capacity so many other people can really get in to see those specialists. So it's a big satisfier because it's also, if you're that patient, now you're accelerated on your care plan without having to wait for another visit, without having to take another day off work or pay another copay. And of course, through the system lens and community lens, it optimizes the limited capacity within specialty care. I think it's a great example of how we're thinking about value-based care and bringing tools to make that more consistently practiced and to do so in a way that accelerates how quickly a patient can get to the kind of care that they need. And you and I both know that this isn't just something that happens miraculously by, as you mentioned, sending an email or popping it up on the screen. We've been firm believers that you have to go a step or two beyond that. And so these tools are very much intended to be actionable. We call them dynamic because it'll pop up the actions that the clinician and the clinical teams need to take and make it super easy for them to order that next test or to put in the referral when it's necessary, or to go ahead and put in a prescription or some other treatment plan when the issue can be resolved directly. I think the other thing that it's done is, frankly, it's forced a conversation between the referring primary care team and the receiving specialty care team so that, given any clinical condition, they're on the same page in terms of how much the primary care team should do, and at what point do you want to pull in those specialists. And so it makes things a little more consistent across the board. And of course, the specialists love that too, because there's a greater reliability of what they're seeing on the receiving end. And so I think all of it is geared towards making sure the patient gets the right care faster, but also to make sure that that specialty capacity and even primary care capacity is used to the fullest.
Well, I got enough glimpses of, evidence-based care everywhere in my time at Geisinger before my board term ended to know that is very, very sound. It is evidence-based. But let me turn to the first category because one of my thoughts at the time was, I'm so busy, I don't have time to, follow anyone else's advice, even if it's good advice. And so when you said multi-payer, multi-provider, early on and describing the way, Geisinger and Cohn are, it suddenly clicked for me. No wonder everything is so much more complicated for those of us living outside of systems like Kaiser Permanente. We've got all these different players to interact with, and that adds this complexity. And that's why I was so interested in the first of your categories, clinician simplicity. It sounded like, that clinicians have to actually adopt these tools and infrastructure investments have to be made to centralized functions like in-basket management. But how are you making that happen? Money is so tight, it's hard to persuade CFOs to invest in new things. I mean, do I have it right? Do Cohn and Geisinger and Kaiser Permanente have to drum up investments in order to make things simple? And are you doing that?
I think you're spot on. I'll go back to we're trying to make sure that the things that can be taken care of in upstream settings, and primary care would certainly be one of them. We're trying to make it so that it's easier to do that, but we also know that the more you're kind of moving things into that environment, we also have to take things off the plate. And there is an awful lot of complexity, especially in pluralistic environments. There's a lot of friction, and we all know that between how care delivery organizations interface with different payers across the board. And so we see that there's opportunity to make that friction easier, smooth out those pieces, and to ease the administrative burden. And some of our tools in that clinician simplicity space do exactly that. I think a couple good examples. One you referenced is there are some best practices around in-basket and how to route it to folks that can respond, or to frankly even use technologies more and more so nowadays to go ahead and respond in a way that's smart, I might say. At the same time, we know that documentation is another great example, and this has been an area that's seen a lot of uptake throughout the industry, and that is easing the burden around, out of office time, documentation, capturing the patient encounters. I think in that space also, there's an opportunity once you introduce sort of ambient documentation tools, the technology is already listening, and there's a way to also hitch other solutions to that. So, we go back to those evidence-based care guides. This one is still in development, but we think there's a way, since the machine is listening, that it could be more proactive in suggesting, which evidence-based care guides might be most relevant, help with differential diagnosis, and sort of be more prompting for the clinical care teams. I think what you hit on with the cost of some of these investment areas and these solutions, spot on. Technology is not free and sometimes requires significant investment. And I think that is one of the big value drivers of being one of the systems within Risant Health, is that you're able to solve for common problems and solve for them once, ease the pain points, and propagate the solutions across many organizations that are looking to do the same thing in terms of the care model. And we've seen that whether it's with the in-basket tools or with ambient documentation, and eventually sort of decision support. We've seen that there's tremendous opportunity in being able to invest in the technologies at scale. And of course, that's easier when you're a bigger system versus, smaller systems. The dry powder, so to speak, is going to be inherently limited in terms of how much of that they can do.
I'm so glad I asked that question because I read your article very carefully and I didn't get the tech investment that was enabling some of the advances that were making these platforms, these categories real. So this is a very, really valuable discussion. Well, let me turn now to another one of the categories, right care, right place. Now, that does sound pretty transformational. Intelligent triage, on demand, virtual care. Are these being used for all patients or all members at Geisinger and Cohn, or just people in the sweet spot of being health plan members and patients of the organization?
No, we're using them across the board. I mean, generally, we're using all the tools across the board, and I think it's easiest to do because it's tough to segment your care model based on what insurance a patient may be bringing in. Now, that being said, of course, payers have sort of care management programs and so forth that may be unique and specific depending on the type of insurance that a patient has. You see that especially in areas like Medicare, or even some employers may have very specific care management programs. But by and large, the tools that we're bringing to bear within the value-based platform, it really is intended for the entirety of the delivery system. I think there is value, though, even when you're not managing a population in a risk-based or value-based model, because you're using your capacity better. And we know the industry writ large suffers from fixed capacity, right? There's only a finite amount of specialty space or clinic availability. There's only a finite amount of inpatient capacity. And when we're able to use that more smartly and more efficiently as a community, I think those communities stand to benefit, because not only do patients have better outcomes, but the affordability of care is also going to be on a better trajectory. We've tried to, the intelligent triage, right care, right place, and the virtual on-demand care. Those are all great examples of when we try to get patients directed to the right environments, so that they're not going to willy-nilly, end up landing in the emergency room because they simply have nowhere else to go, or because it's not easy to get to those places. Maybe it's my bias as, someone with who's an ER physician by training. I know a lot of people land in the ER simply because there aren't really viable alternatives for where to go. And so if we can figure out how on the front end to do the better air traffic control, if you will, and present those options to patients, it shouldn't surprise us, the results that we've seen. And what we've seen is, people otherwise intending or contemplating the ER, when they use that tool, 92% of the time, they're likely to go somewhere else other than the ER, or have their care needs addressed through the tool or through virtual on-demand care. And so it goes a long way, of course, from a care affordability standpoint, from a value-based care standpoint, but it's also a tremendous patient satisfier, because they're going to get their issues resolved without going through, the 4 or 6 hour waits that you would typically see in most ERs across the country, the extra copays, not to mention ER overcrowding and the experience that brings. And so it really is one of these twofers, if not threefers, where the patient has better care, their experience is better, and it drives down total cost of care. And so it's another great example, the right care, right place, of what we're trying to do, and more importantly, why.
Well, I was thinking as you described these dynamics that our economist friends would be thinking of the phrase free rider. And I'm so glad you are not letting the fact that patients with other types of insurance are going to benefit from these plans, that is not keeping you from going forward. That is both being charitable, but also showing leadership. So I'm really glad you're doing it. I also was wondering, as an ED doc, like whether you watched the TV show The Pit and how these systems would play out in that emergency department. But that may be a long discussion, best had over a glass of wine after dinner. Um, but let me turn to the part of the platform that made me really jealous, and that's Care Without Delay. Can you describe what it does and how the heck you implemented it in places where everyone already feels like they're working as hard and as fast as they possibly could?
This one's been a game changer. I think what a lot of folks don't fully appreciate, and you do because you have lived your life inside a care delivery organization or inside an organization that's working with a lot of care delivery orgs. But throughout the industry, patients admitted on a Friday have a very different experience than patients admitted on a Monday. And it's because there isn't the same consistency of what's available in a hospital between different days of the week, let alone different times of the day. I think Care Without Delay is really about creating consistency of no delays in what a patient experiences as they go through their hospital stay. And by focusing on those things, lo and behold, they spend less time in the hospital. And it's really bringing 21 component elements, doing them reliably, and some of this may be more consistent staffing of ultrasound techs on a Sunday afternoon where otherwise they wouldn't be there, or MRI folks at different hours of the day. Echo techs. There are all sorts of rate limiters that come into slowing care down when it comes into the hospital. And Care Without Delay, as the name would suggest, is about making sure that those delays disappear. By doing that, what we've seen, and again, this shouldn't be a surprise, pretty intuitive, we've seen that hospital flow improves. We've seen that people spend less time in hospitals. We've also seen that they spend less time boarding in the ER, talking about The Pit. It's interesting. We were recently binge watching that show. My wife was asking me, is it really that busy typically? And it absolutely is for anybody who stepped into a pretty busy ER. But ER boarding and what that means for those of you that may not be as familiar, these are patients that are supposed to be admitted, waiting for a bed upstairs. But for the segment that's actually waiting either for an ICU bed or a cardiac monitored bed, there's some ER literature that would suggest that if they're boarding in the ER, i.e., waiting for longer than 6 hours, then their mortality goes up by 16%. That's a significant difference in care and outcome experience. And it illustrates why this work is so important. When people spend unnecessary time in ERs or hospitals, it's not a good thing clinically. And so Care Without Delay really seeks to make it more consistent so that they're not spending that unnecessary time. It also uh, makes the team more aware and managing what led the patient to the hospital in the first place or the ER and what may be coming next. So plugging the gaps so that, hopefully you're able to discharge them home. But if not, working together with those post-acute care facilities and making sure the handoffs reduce the chances that they're likely to come back in and need additional care in that hospital environment. And so we've seen tremendous impact from this, length of stays reducing by 4 or 5%, depending on where the hospital campus is starting from. And again, flow through the ER significantly different. We've seen significant kind of ER boarding time reductions of 30 to 45%, depending on the campus. And all of that equates to better outcomes for patients. So we're pretty excited about this one.
Yeah, that was one of the things that astounded me in my time at Geisinger was seeing Care Without Delay decreasing congestion in the emergency department. Well, I'm glad to hear you and your wife are binge watching The Pit. My wife and I did the same thing. And it occurs to me that we can probably recommend to innovators from now on, to ask themselves the question, how would your innovation work on the pit? And if they have trouble picturing it, then they should probably do a little bit of redesign. Well, let me come back to the question I started with. How's it going, J1?
I mean, look, we've made a lot of progress over these 2 years. It's gone really fast. I think one of the things I'm most proud of is we're really demonstrating that value-based care can happen and can be truly quote unquote valuable in multi-payer, multi-provider kind of pluralistic environments. It can help health systems use their capacity better, and as a result, patient outcomes are better, population health outcomes are better, and affordability in the community gets better. And so I think that's been one really cool finding for us. It's confirmed the thesis. And then the second is that innovation does benefit from scale. And yes, things are never as fast as you want them to be, but when you're able to solve for a common pain point once and propagate the solution many times over, I think you end up going at a pace that's faster than the alternative, and that's been great to see as well.
Well, I want to thank you so much for taking the time to write that article and then to go deeper and talk about it. I know it's been very useful for me personally, and I think a lot of our readers are going to have the same kind of gratitude. And I know that we'll be getting more progress reports from you, and I hope more discussions. And so thanks so much for doing this work.
Thanks so much for having me, Tom.